Everyone. Welcome to session 11 of the Oxygen Therapy and Critical Care case-based series. Today we'll be talking about essential emergency and critical care with our esteemed panelists, Dr. Papytcho, as always, and Dr. Hope and Dr. Sipuka. Very excited for today's session, our second to last session. So without further ado, I will pass it over to Dr. Hope to get us started today.
Okay. Thank you very much, Sarah. Good afternoon, everyone, and everyone participating in today's classroom. As Sarah mentioned, today we'll zero in on essential emergency and critical care. I think throughout the session, you may see the symbols, the letters EECC. So this is what we're talking about today. And then I think it's a timely topic, looking at the impending fourth wave in most of our settings. Okay. Sarah, can we go to the content for today? Okay, so throughout today's session, we'll be referring to our patient, Mr. G, a male 61, who presents to the local emergency room with shortness of breath, dizziness, and diarrhea of 7 days duration. And what we anticipate today in terms of our practice change objectives is that we should explore acute care, critical care, and intensive care. We look at the domains in which acute care occurs in our hospital, pre-hospital setup. We recognize that critical care is a continuum of care. We define what EECC is. We recognize the key domains involved in it, which are identification and the actual care involved. We determine critical illness using warning signs, and we look at some examples of scoring systems. The other objective is to improve care for patients who come in critically, no matter the underlying condition. We identify the clinical processes which are needed for EECC. We recognize the components of hospital preparedness which are needed for us to provide essential emergency and critical care. We analyze the gap in our institutions, especially in terms of resources. We look at the implementation with whatever resources we have available. And then for us to advocate for additional resources, especially in the advent of COVID-19 in terms of medical oxygen. Okay, Sarah, we can move on. Okay, so this slide, I think this is the data in terms of the daily oxygen demand, especially for COVID-19 as of June 4th, 2021. This data is for low and middle income countries, or what we call variable resource setup. We can see here that as of June 4th, this resource this is 18.1 M, 18 million actually, 100,000. But if you look at the data as of November 17, looking at this path oxygen tracker, we're talking about we're looking at 8.3 million cubic meters of oxygen supply, which is needed per day. So that is the latest update from 17th November. And all of this has got financial or cost implication. So it's estimated as of 17th November that the annual cost for this level of need of medical oxygen is about 1.6 trillion US dollars. So you can see that this is quite a huge financial implication, which we're talking about. For more information, you can click on the link, and then you will be taken to a country by country requirement for oxygen. Okay. All right. Sarah, we can go back to the main presentations. I would encourage all the participants in today's classroom to do this at their own time. Okay. So we go back to our case of Mr. G today. So the setting is that you are working in a rural district hospital. The nearest hospital with an ICU setup is 40 miles away. The physician who is working in the emergency room calls you to see a patient that she wants to admit to the hospital. The history of this current illness is that Mr. G is a 66-year-old man with 7 days history of dyspnea, dizziness, and diarrhea, and he reports feeling weak. His dyspnea is worse with exertion, but gets better with rest. And he reports that he received a COVID vaccine, a single dose vaccine 4 weeks ago. When you perform his vitals, when you check his vitals, you find that his respiratory rate is actually 27 breaths per minute. His heart rate is 97 beats per minute. His BP is 107/59. His temperature is 37.5 degrees Celsius, and his saturation, oxygen saturation on room air is 91%. He is placed currently on 3 liters per minute of oxygen therapy via nasal ponds, and immediately his saturations improve to 95%. Okay, so that is the background of our patient today. So in the next segment, I'm just going to encourage us to pay particular attention to the practice change objectives, which are to explore acute care, the concept of acute care, critical care, and intensive care. We look at the intricate differences between them. We look at the domains in which acute care to any patient can occur, and how to recognize the critical care spectrum or continuum. I'll ask Dr. Papytcho to come in and take us through this session. Dr. Papytcho.
Thank you very much, Dr. Opp, for the nice intro. We would like to have an idea on how WHO define acute care. There could be different definitions that you can get in different places, but WHO being the body leading in terms of healthcare, we would like to acquaint ourselves with the definition from WHO. Sarah, you can go up, please. So there are different steps that WHO consider when it comes to acute care. Okay, so they will define acute care like that is to have said down. Yeah, it's a care that is able to change the outcome of a patient immediately that is being offered. So for a patient who presents with a life-threatening condition, immediately that you attend to them, and then the little act that you make for them to change from life-threatening to a stable condition is already an acute care that you deliver. So acute care is time sensitive. When it's given at the right time, the right person who's being identified to have a life-threatening condition, it helps changing from life-threatening condition to a stable life. So that's how WHO consider acute care being defined. There are many other medical definitions that can be attributed to acute care, but the essence is like it's a care that is given at a specific time when there's a life-threatening, and then giving out a change in terms of condition for the patient. So we would like to know, where does acute care occur? It's somewhat like somebody asking, where does the general condition of the patient change from? As we know, the general condition of the patient can change from everywhere in the world, can change from the acute emergency room, can change in the ICU, in the theater, at any point where the patient can be identified, and then changes occur. As you can see down here, there's a diagram showing different domains where patients are found and where life-threatening condition can come to. So like when you are in the emergency department, you can be in the trauma or surgical ward, you can be in the ICU, you can be in pre-hospital, or it can be soon after being discharged. So everywhere life-threatening condition can come and acute care can be given to patients. And as we said earlier on by WHO definition, it's all act that you pose on a patient to change the outcome based on the time intervention. So how would you define critical care? And then where does it occur? And how does critical care differ from intensive care? So you can click on the, yes, thank you. So in this article, which was written by our colleague who are into emergency care and the ICU, they happen to show how it moves from the emergency to the ER, ICU flow, and home rehabilitation. So the whole idea here is that the arrow moves from the admission and the wish is to go out for rehabilitation after prompt action on the time-based identification of the condition that is life-threatening. So this can occur at everywhere, as we said, on the patient flow, on the patient pathway, and once it occurs, it can be identified by anyone and everywhere in the institution or in the pre-hospital location. What is needed is to give the ideal care, to do the ideal maneuvers, or to give the ideal care to move from life-threatening condition to a stable patient. So this article is on the website. You can go for it and then it will give you more information about it. But the little more that we can add is to make the difference between critical care and ICU. So critical care is a continuum care everywhere at every time when you observe that patient has changed condition, their critical care start already, and then you start by giving the ideal treatment. But ICU is simply a place where the care is given and where there's an assembly of different type of equipment that can facilitate the care to be given. But what matters here is the type of care that you give, because even in the ICU, you can still give your acute care, and then patient can still change condition and improve their stability. So as we said earlier on, the patient continuum after ICU discharge must also be taken into account during their stay in the ICU. So with attempts made to limit the longer-term physical and psychological consequences for critical illness as much as possible. So patients who are home, they also need continuum care. The care can be given or can be taken up by the relatives, or can have visit for psychologists, can have visit for health practitioners, just to make sure that the patient who's at home does not suffer for any ICU complication. After long stay or short stay in ICU, there's some other complication that can follow, and which might need a special care from a different category of healthcare practitioners or anyone that is involved in the care of the patient. So for our patients, we're gonna share a case update. We happen to discover that the past medical history, it has nothing special. The patient state is otherwise healthy and exercise regularly, playing football, which can be called somewhere else soccer. On the surgical history, he has none, is single, living alone, and occasionally taking alcohol. Is not on any medication and it doesn't have any non-allergy. It denies any hematemesis, melena, or hematocracia. It denies chest pain or fever. On the CT chest with contrast, it shows bilateral interstitial pneumonitis patterns consistent with SARS-CoV-2, which is SARS-CoV-19, but no pulmonary embolism which was seen. On your assessment and plan, you as the physician, you decide the patient is to be admitted to the hospital ward with oxygen therapy. You start him on antibiotics for community-acquired pneumonia, and you add some dexamethasone for possible SARS-CoV-2 infection. Further tests and workup are in process. You can go up, Sarah. Yeah. So after that update, we would like also to have a short discussion on the Lancet burden of critical illness in adults. So basically, the global burden, it's difficult to be defined because critical illness can't be a single sign or can't be identified by a single sign or a single test. It's a all association of procedure, of techniques and knowledge put together. Okay, so even if critical illness occurs outside of the ICU, data is usually collected within the ICU, and this data is incomplete in the ICU settings and can make it not enough to make up a final decision on how to go away with the patient. So usually it's important to compile all the data from the time the patient entered the hospital until when is in the ICU. Remember, it's a continuum of care. There's no interaction in terms of care. And then as you assemble all the information that you have, and this can help you to come up with a better and strong diagnosis, which will lead you now to a better care for the patient being optimized and a better outcome for our sick patient. So always remember that a single diagnosis will not make up a solution, or a single test will not make up a solution for a critical ill patient. It's all about summarizing from the time the patient was admitted up to the time when you're seeing the patient, everything put together for you to come up with a tangible diagnosis and a better solution to alleviate the pain and the struggle that the patient is going through. So we'll end up our first session asking you this question. If Dr. Ndaba is there, it can pick it up. Continue from there.
Oh, thank you so much, Dr. Ntambwe, for that very wonderful discussion you had. I'm sure our participants are really appreciating these conversations. We will only urge them to actually visit the website for all these resources. So we might not discuss all the details now, but this is just to give you an introduction and overview, as well as to guide you on this information. And then at your own time, feel free to access these resources on the link that will be provided in the chat box. Thank you so much, Dr. Papytcho. So continuing with the discussion, the next question we have now is, which of the following are considered critical patient care? Which of the following are considered critical patient care. So this will be a poll. Feel free to actually click on which of these 5 items are considered patient care. So there's a poll that is going on. Just choose any of these responses based on what you understand to be elements of critical patient care. So let's do the poll, Sarah. So, hey Sarah, sorry, I can't see the poll. Maybe it's just my screen.
Oh, the poll is going. We have
It's going.
55% of participants have responded so far.
Okay, I don't seem to actually see it on my screen. Yeah. Yeah, so thank you so much for the responses that we've gotten so far. Yeah. So yeah, so we can already see that the highest percentage of our participants have chosen option number 5, which says all of the above are considered critical patient care. So this is wonderful. It means our participants already have an idea of what we are discussing today. So this is very impressive. So actually the answer is option number 5, which says all the above are considered critical patient care elements. So early recognition, assessment, and decision-making for deteriorating patient. This is actually a key element of critical patient care. It actually starts with recognizing a critical illness, and this will then guide on the most appropriate actions based on assessment and recognition. This is followed by rapid and timely intervention for patients at risk of clinical decline. So option B is an answer here. So identification of clinical warning signs prior to cardiac or respiratory arrest. This is also a very important element of critical patient care. So it's all about recognition and identifying specific early warning signs that we are going to discuss in the subsequent sessions prior to a patient going into either cardiac arrest or respiratory arrest. The 4th option reads providing expert assistance in response to concerns for a patient status. So once you monitor, as you are monitoring the patients, and then you notice some early warning signs, some red flags based on the assessment, maybe of vitals, the SpO2 is falling, or the blood pressure is falling, or various other clinical deteriorating signs, the next thing is actually to summon appropriate help or expertise, depending on whatever is available or based on the patient's clinical condition. So you call for help so that you can provide maximum care for this particular patient whose condition is deteriorating. So all the 4 are correct responses and are considered elements of critical patient care. So we can move up, Sarah. So the next session's practice change objectives include, we are going to define what Dr. Piri introduced as the main topic for today, which is essential, emergency, and critical care, EECC concept. We are also going to recognize the two key domains, the two most important elements of the essential emergency and critical care discussion. So these two will mainly be identification of critical illness as well as care of critical illness. So it's identification and care of critical illness. Then we'll determine critical illness using the early warning signs as well as the various existing scoring systems. And then we're also going to discuss improvement of care for critically ill patients through education, training, guidelines, protocols, as well as use of cognitive aids. So you have different aids that you can actually use to provide care for these patients. So slide upward, please. Yeah, so the next poll is a true or false question. So critical care and emergency care require expensive technologies and highly skilled healthcare providers. True or false? Critical care and emergency care require expensive technologies and highly skilled healthcare providers. So let's see what your opinion is based on the question. Do you think that critical care or emergency care really requires high-level technology, high-level or expensive equipment for you to provide this service? Okay, so thank you so much. So we can see that here we have a tie. Half of our participants actually think that for you to provide critical care and emergency care, you require expensive technology and highly skilled healthcare providers in your facility. Whilst the other half again think that you actually do not require expensive technology or highly skilled human resource for you to be able to provide critical and emergency care. I wish we could do another poll just so we have a winner. So we have a tie. So actually, in as much as depending on the environment where you are, actually you would agree with me that really for you to be able to provide the basic critical care and emergency services, most of the times you actually do not require very expensive technology. You do not always require highly you don't require experts, all the time. So with basic critical care and basic emergency, it's actually the little things that we actually even have in our institutions that when we utilize effectively, we would be able to provide up to a greater degree critical care and emergency care. So it's actually not always that we need very expensive technology and highly skilled human resource that we should be able to provide critical care and emergency service as well. In most of our facilities, actually, we may not even have access to this very, very high technology or highly skilled manpower. Yet we have the ability to provide adequate emergency care as well as critical care facilities. So it is actually the simple things like, you have the monitoring, you have the suction machine, you have the basic drugs that you need. We have basically trained critical care nurses. We have and other human resources that are able to provide a basic critical care, basic emergency service. I think that's what is crucial, as opposed to high technology and highly skilled human resource. So with the little resources that we have in our facilities, with correct use and application of those minimal resources that we have, we should be able to provide optimum care for these patients who require critical care. Yeah, so in as much as technology is important, in as much as having a skilled human resource is always necessary, but this does not really limit all of us from being able to provide basic critical care as well as emergency care. So again, visit our learning resource centers for the detailed guide on what kind of resources we need. So we can go up, Sarah. Yeah, so we have to define what essential emergency and critical care is. So again, we will not cover everything in detail here. There's a very, very important article that has actually explained in detail what this element is all about. And I would like to encourage all our participants actually to refer to this article to have a deeper understanding of what essential emergency and critical care processes involves. So we can go up a bit, Sarah. So literally, we define EECC as care that all critically ill patients should receive, irrespective of the environments. We have limited or low resource environments. We have those other environments which have access to all the equipment and everything. But in EECC, the philosophy is that we should be able to provide at least basic but appropriate care to all critically ill patients that requires this service. So this is a concept that should be a crucial part of universal health coverage. So every patient should have access to this service. It is low cost, meaning that ideally you do not need very sophisticated equipment beyond what we are able to have in our facilities. As long as whatever we have, the minimal equipment we have, we put it to good use. The minimal skills that we have, we apply them appropriately. We should be able to provide some level of care to these patients. Yeah, so it is actually intended for patients irrespective of age, gender, underlying diagnosis, medical specialty, or location. So really, you do not need to have a diagnosis for you to be able to resuscitate these patients, whether you are in the ER or you are in the general ward, where the patient develops critical illness. You do not need to have all the sophisticated equipment. So EECC is a set of actions and treatments. So you have actions and treatments plus the system-wide requirements for their provision. So what is important is actually recognition, followed by action and treatment. Then we discussed earlier on that we divide EECC into two important domains, which is the first one is identification of critical illness or recognition of critical illness, followed by action or provision of care. So we have identification. On the other arm, we have care. So the subsequent discussion or sessions actually will discuss these two in detail. Yeah, so so lastly, we need to identify a case and provide care for that particular with respect to hospital readiness in terms of resources that are available at that particular institution. So in the next sessions, we'll go through some of the elements, some of the requirements that you need for you to be able to provide this care. So we can go up, Sarah. So, so like I mentioned earlier on, we are going to focus on the two key elements of EECC, which are identification and then care. So in terms of identification of critical illness, which is the first discussion line. So we have this patient now who is sent to the ward. Despite initial oxygen therapy at 3 liters per minute via nasal cannula, 2 hours later, the patient's SpO2 starts falling. Remember, the patient's SpO2 had gone up to 95. Now it's falling down, and now it's at 86%. So you can already see that this is a typical example of identification of critical illness. So what is the clinical problem that we have identified here? You can scroll up, Sarah. So what is the exact clinical problem that we have identified here? So we have seen already that the SpO2 is falling, and this does not really require highly skilled experts to recognize, or sophisticated equipment to recognize. The only thing you need is just a pulse oximeter, and we have pulse oximeters in most of our facilities actually. So the big questions are, who is responsible for identifying this problem? What is needed to identify the problem? What should happen next? So we are talking about identification of the problem. So later on, we'll discuss some of the tools that you need to recognize critical illness, some of the human resource requirements for you to be able to recognize critical illness. Yeah, and then we'll also talk about what kind of care, what do you need in order to provide care to these patients. Can scroll up, Sarah? Yeah, so the ward nurse calls you. When you arrive, the patient is alert, but appears to be working harder to breathe. So he can only speak 2 to 3 words at a time. So clearly you can see that the work of breathing is increasing. The respiratory distress here is worsening. So the respiratory rate currently is at 27. The temperature is at 37.5. His heart rate is at 93 beats per minute, and his blood pressure is 112/79 millimeters of mercury, and his saturation still remains low at 86%. So clearly we can see that this is a patient who is deteriorating. And so since we are identifying, so we can see from the vital signs already that this patient needs some high level of care, which will be the focus of the discussion in the subsequent sessions. So you can scroll up, Sarah. So at this stage, I will invite Dr. Piri just to come and take us through the next phase, which is the rapid response systems. Remember, we discussed who should be able to identify what kind of structures or human resource structures that you can put up in order for you to identify critical illness. So Dr. Piri will go through the subsequent sessions to discuss these elements. Dr. Piri, are you there?
Yes, I'm here, Dr. Spuka. Thank you. Okay, so the question that we have here is, what is an example of a hospital system that serves to identify patients who are deteriorating before they become critically ill? Because this is the key question. You need to be able to identify these patients so that you prevent them from developing critical illness. So one example that we have here, I'll read this excerpt from the Patient Safety Network. This is an agency for healthcare research and quality. So patients whose conditions deteriorate acutely while in a hospital setup often exhibit warning signs. A good example are abnormal vital signs in the hours or minutes before experiencing adverse clinical outcomes. So what this means is that a patient will have early warning signs. There will be signs that things are not going okay. So in contrast to a code blue team, for instance, for cardiac arrest, which is usually called when the patient's condition has tipped. The rapid response teams are designed to intervene during the critical time. Once you identify that the patient is deteriorating, this is the optimum time for us to intervene and salvage the patient from developing critical illness. So this can be applied to patients who are on a general surgical ward, medical ward, or an admission ward. So this is from the Patient Safety Network. Sarah, please scroll down. So here, I'll just take a minute to look at the warning signs that patients may exhibit prior to deterioration. Please, Tim, if you know any signs that a patient may exhibit before deterioration, please feel free to throw them into the chat. List 3 warning signs that patients may exhibit before deterioration. Patients in a hospital setup. How can you tell that a patient is changing condition? Please feel free to throw your answers in the chat box. Okay, so I haven't seen any answers, but really looking at, okay, I'll give it great. We have an answer from Gael who says a decreased heartbeat. Okay. Tachypnea from Richard. Okay, the answers are slow to come, so I'll go through them. We heard from the excerpt that I read that vital signs may be deranged before a patient deteriorates. So vital signs such as the heart rate may be decreased above the normal, the upper limit of normal. So typically a heart rate above 140 would tell you that this patient is changing condition. A heart rate below 40, a respiratory rate above 28 or below 8, systolic blood pressure of above 180, and systolic blood pressure of below 190. If your saturations on room air are 90, your patient is not on supplemental oxygen, but their oxygen saturation is at 90. That's a red herring for deterioration. If your patient changes mentation, that is also an acute change in mentation, is also an early warning sign. Urinary output, a urinary output of less than 50 cc's in 4 hours is also a red herring. Generally, if a member of staff exhibits significant concern on the general condition of the patient, that should not be ignored, but should be taken as an abnormal vital sign, which is an indication of changing condition. So if you click on the link, which Sarah has done so, you will find that there's an article on rapid response teams on the Patient Safety Network. And this one gives a good background and overview on the issue of, or on the concept of rapid response teams and what their role is in the medicine we're practicing of our times. So please feel free to visit the Learning Resource Center. It also tells us the system models which are available in different countries. For instance, Table 1 shows us a medical emergency team. The personnel in this medical ward could be physicians, they could be critical care nurses, critical care or hospitalists, or general ward nurses. And their duty could be to respond to such emergencies follow up on patients, especially post-ICU discharge, basically to be proactive on many patients who are discharged post-ICU. You could also have a rapid response team model, which is comprised of a critical care outreach team. This will be led by a critical care group, physicians and nurses and clinicians. Their duty is to proactively evaluate high-risk wards patients, educate ward staff, and respond to emergencies. You also want to always keep an eye on patients who are post-ICU admission. It could be a rapid response team, which is which has got many specialties in it, comprising of critical care nurses, respiratory therapists, physicians, or any other backup staff that you could have. And the role is the same, to respond to emergencies and to proactively source or search for patients who are at risk of deterioration. So this, I think, would like to think of a rapid response team as like it should be like a reflex arc with two limbs, your afferent limb, which is the calling, and then the efferent team, which is your response team. So there's the calling and the response or responsive limb to it. Sarah, please take us back to the main discussion. So we've talked about the 3 warning signs. So vital signs are cardinal, change in mentation is cardinal, significant distress or concern by any clinician attending to the patient, that should also be a trigger for us to detect deterioration in a patient. We'll move on to the next segment. Remember, we were introduced by Dr. Spuka, who told us that 1, the cardinal thing is to identify critical illness and then provide the care for this critical illness. So how do you, as a clinician, identify that this patient is changing condition? One of the things that we have done traditionally, especially here in Zambia, is to assess a patient clinically. We clerk the patient, take an appropriate history, examine them. But there are other techniques or there are other tools that we can use to help us arrive at a score which could predict deterioration. There are a lot of tools which are out there. I would encourage you to download the MedCalc calculator. It's an app which could install on your phone, and the various trigger tools that you could download. In this particular session, we'll talk about the news score, particularly the news 2 warning score. So this is the National Early Warning Score, which is used in I think in the United Kingdom, and it's been adopted or it's been recommended for use by their overall body, which is the NHS. And the news 2 score has shown to be more superior to the news 1, to the original news 1. So this tool is actually, this tool has actually been recommended by the Royal College of Physicians. When do you use this tool? You want to use this tool in your non-obstetric adults. So you're looking at patients who are not pregnant and they're above 16 years old. It has not been validated for use in children below the age of 16. And we are very cautious of using such a score in patients with autonomic dysfunction, such as patients with spinal cord injuries due to the autonomic instability. When can you use this? The Royal College of Physicians recommends using the news score in the following settings. It could be in an emergency or acute setting during your initial assessment of a patient. You could also use it to monitor your patient to check if they're improving or deteriorating. And you could also use it during triage as you are sorting out your patients according to illness severity. So assessment during triage. In a lying-in ward, you'd want to use your news score for inpatient assessment and also serial monitoring for improvement and deterioration. It's a much more objective tool to use, especially if you're going to hand over to a colleague. So you've got a much more objective method of assessing improvement or deterioration. The news 2 score can also be used in the pre-hospital setup. So this is a very good tool that you could use to communicate the severity of illness of your patient before you to a receiving hospital. So how does it work? Sarah, we could go back to the main discussion. How do you actually use the NUNS2 score? So there are several parameters which are measured in the NUNS2 score. Number one is your respiratory rate, your patient's respiratory rate, that is. So in this version, which is being projected, this is on the MedCalc, you simply input your patient's respiratory rate. The second parameter that you're going to look at on a yes or no basis is whether you've got hypercapnic respiratory failure. The third parameter is your oxygen saturation. What is the oxygen saturation of your patient if your patient has got hypercapnic respiratory failure? The next parameter that you're going to look at is, you're going to comment, is your patient on room air or are they on supplemental medical oxygen? So this becomes very useful. So you tick, if you're using a calculator, it makes a MedCalc, for instance, it makes it very easy. You're also going to look at other parameters such as temperature, and this is graded. This is graded, it's a bidirectional grade. So there's it's a unidirectional grade, positive, but it goes both ways, whether your patient has got a low temperature or a high temperature. You also have your systolic blood pressure. So you're going to look at what your patient's systolic blood pressure is. This is used as a surrogate of your organ perfusion. You're also going to input in your calculator the pulse rate of your patient in beats per minute. So you simply tick. After you do this, you move on to the last parameter, which is the conscious level of your patient. Is your patient alert, or is there a new onset confusion? So this, you could also use the AVPU. So this is your response. Is your patient alert, responding to voice, pain, or are they unresponsive? So this gives you a good grade or a good idea of your patient's conscious level. The last parameter really, which has been put there, is really for research purposes. It doesn't have an impact on your final results. So you just want to input, is your patient a SARS-CoV patient? Are they confirmed, suspected, or are they unlikely to have SARS-CoV-2? So looking at, I think looking at what Sarah has inputted, you find that our patient has scored 7 points. So for every parameter which predicts deterioration, there's an upward increase in your score. So 7 points, according to the NUNS2 score, is a high risk score. The clinical implication is that this is an emergent assessment by a clinical team, and this patient needs transfer to a higher level of care. And during that time, they need more frequent monitoring. This is not a patient you want to assess once a day on your ward round or as you are taking your vitals. This is not a patient you want to assess 4 hourly, but you want to have more frequent monitoring of vitals. So this is how the NUNS2 score can be used. Please remember, participants, that there are a lot of early warning scores that you could use. Pick one which is appropriate to your setting. This is just an example of one of the tools which has been validated for use, and it's being recommended by the NHS. So there are many. Please pick. I think we discussed them in prior sessions. Sarah, please take us back to the main session. Okay, so we've now moved to the second part. We've identified that this patient, Mr. G, before us, has got critical illness. We now need to talk about the care. How do you provide care to someone who is critically ill? If we look at our update, you've decided to increase Mr. G's oxygen therapy by switching him. You've decided to escalate the therapy by switching him from the nasal prongs, which you had initially put him on, to a mask which has a reservoir bag. So this is our NRB that we keep talking about, the non-rebreather mask. And by doing so, what you have done also is increasing the oxygen flow rate from whatever oxygen source you're using. You've escalated to 15 liters per minute. Okay, so I'll take a pause there and I'll ask, I'll just make a comment. So what you have just done, by identifying that your patient needs escalation of oxygen is an example of care of critical illness. So this is a very good example. You identify that there is a problem, and the next thing that you do is take action, medical action. So you've switched the patient and you're trying to optimize his oxygen therapy. By doing this, you are trying to achieve the goals of EECC. So it comes back, we get back to our question for today. How do you, as a healthcare worker or healthcare provider, know how to give the appropriate care? We've talked of intervention, we've talked of identification, but how do you know the type of care to give to a patient? Can be quite overwhelming, especially when you're in a COVID isolation center and you've got critically ill patients who have filled up your wards. How do you know which type of care to give to each particular patient? So please scroll down, Sarah. Let's expound on this. Okay, so there we've got a diligent healthcare worker who has got his resource, his phone in his hands. So there are many ways in which you could give appropriate care. One of the prongs is education and training. We'll talk about 3 prongs today, but I'll start with education and training. What makes us different as healthcare workers compared to our colleagues working in other specialties is that we've received the appropriate education and training to give medical attention to patients. And also in the past, in 2020 and 2021, we have also received additional training, short trainings, long trainings on education and training in critical illness, because most of our COVID-19 patients are coming in with critical illnesses. There are a lot of short courses and there are a lot of resources which you could delve into as a concerned healthcare worker. On the Learning Resource Center, what we have links to websites where you could receive education and training in basic emergency care. One such link is the one which is being projected online. So please, at your own time, feel free to explore all of these resources, which will help you give the appropriate care to patients. So it is only through education, training, and practice that our recognition of critically ill patients will actually translate into patient care on the bedside. So this is the World Health Organization. Okay, that's fine, Sarah. But this is one example, the basic emergency care approach to the acutely ill or acutely injured patient. And you'll find that with critical care, the approach, whether medical or surgical, is similar. So there are a lot of slides, there are a lot of presentations which you could download and go through. So by continuously reading and updating yourself, you'll be able to give appropriate care to your patient. Okay, Sarah, let's go back to the main slide. Okay. So the second prong to this care, appropriate care, is to actually use guidelines and protocols. Guidelines and protocols will guide us. These are evidence-based and usually validated protocols which have been put up looking at the level of evidence for a particular intervention. So there's so many critical care guidelines and protocols that you could use as you care for your patients. You could download these in an app, or you could always look at them online, or you could have booklets, which we do have booklets which have been circulated, especially for obstetric and pediatric anesthesia as an example. So on this page, there are 6 websites which are listed on the Learning Resource Center. So all of these critical care guidelines will help you to build your clinical acumen and skills as you provide appropriate care to critically ill patients. We also have specific COVID protocols. So there's a website called covidprotocols.org. This will help you as you're planning your treatment plan for your patient. Okay, so all of these are free resources that you can access at any time on the website. Okay, thank you, Sarah. Let's move on. So why should we rely on protocols and guidelines? One thing that I found in my own experience, I'm not sure if the participants this would resonate with them, but during the stress of having a critically ill patient, or when you have a critical incidence, a lot of us clinicians are more likely to make mistakes. You may not remember your formulas well. You may not remember your drug doses well. But if you have a guideline or a protocol and it's stuck maybe on your notice board, it becomes easier for us to follow up. So we're more likely as clinicians to implement this if we know what the best practice is for optimal care. So having this, especially for those of us who are running hospitals, it would be a good initiative to print these out and laminate them and stick them on our notice boards so that in the heat of the moment, we only have to look on the notice board and then calculate according to the patient who is before us. The last prong in the care of a critically ill patient are the cognitive aids. As stated above, Sarah, sorry, we can move on. As stated above, during the stress of a critical event, the vast majority of us clinicians don't implement the best practices optimally because we're under stress, so we make a lot of mistakes. So cognitive aids will help us to give the appropriate care. Sarah, please scroll down. So there are a lot of manuals that you could use in different setups according to the emergencies that you have. As I mentioned, you could have it as an app, or you could have a little booklet. It tells us the common emergencies that could happen. If you're dealing with critically ill patients, most of the emergencies which occur are quite common. It could be that your patient has had a cardiac arrest. It could be that your patient has got hypoxemia, as we're seeing in COVID-19. Your patient could be hypotensive, or there could be specific events. If it's an obstetric patient, you could have amniotic fluid embolism. It could be anaphylaxis, and this may go unnoticed if you do not identify it. We could have a bronchospasm, a difficult airway as an example. You could have a fire in your isolation facility because we have oxygen around us. Your patient, especially if it's an obstetric patient, could have hemorrhage. So there are a lot of emergencies which could occur, and it's very helpful for us to have manuals that we could refer to in the stress of the moment. Okay. So all of these resources, as I mentioned, are available on the Learning Resource Center. Okay, let's move on. Sarah, you can please scroll, you can keep scrolling downwards. Okay. So we've come to the end of this session. As we go into our breakout sessions, I think we'll spend very minimal time over the next 20 minutes, odd minutes or so. I would request Assist to break us into breakout sessions where we discuss how do we conceptualize EECC in our hospitals. This is one aspect I think I've mentioned in terms of the universal health coverage, which we do not really emphasize on. But COVID-19 has shown us that we do have surge capacity. Sometimes you have critically ill patients presenting at the same time, and all your hospital resources could be overwhelmed. How do we prepare for that? So for this session, we're going to look at the list. We're going to list the clinical processes which are needed to identify and care for critical illness. We're also going to recognize the components on hospital preparedness which are needed for us to provide essential emergency and critical care services. And remember, this becomes very important as we prepare for the impending fourth wave. So at this point, Sarah, please, I would advise you to just guide us on how we're going to proceed into our breakout sessions.
So Dr. Opp will have two groups.
Okay.
Yeah.
Okay, that's fine. Sarah and the technical team at Assist, please put us into two breakout sessions. We'll be looking at some of the practical aspects of EECC. So Dr. Ntambwe will take us through. Dr. Ntambwe will take us, myself, I'll talk about the clinical processes. How do you identify critical illness and how do you manage some of these conditions? While Dr. Papytcho will look at some of the gaps which are there in our facilities and how do we try to address some of these gaps? So please, we can break into those sessions.
Yes, you'll be moved into a breakout session momentarily. We can launch those now. Just give us one moment for Manjeet to launch those.
Sarah, if we can't break today, it's fine. We could go ahead.
Manjeet, how are we doing on breakout?
Yes.
Are we able to launch those? If the breakouts that might be helpful.
Okay. Would Dr. Papytcho start?
Okay,
Dr.
good. I can start, and then Sarah, we can go back on the main screen, sharing the main screen, so to just show where the gaps are and then what to do. Down, okay. So you can know the.
Tell me where to stop, Dr. Papytcho.
Actually, the previous table should be up there. We just use that table and then. So we use this same table. Please, you can enlarge it, the table one. And take it a bit up. Yeah, we use it to identify the gap that we can have and how to sort it out. So as we discussed in the previous chapters of this lecture, we're told that EEC has two big components, identification and care. So when you look in the identification, there's structure that also need to have for you to identify. So if you want to analyze now our institution, our respective institution, and to see what is the gap that comes into identification, what are you seeing that could be the gap that usually come leading to failure of identifying the critical ill patient? In identification, what are the things that we need for you to identify a critical ill patient? There we can talk of human resource, we can talk of gadgets, we can talk of consumables. So is it like we lack gadgets, we lack human resource or consumables? So if we identify this, what is the thing that we have done to sort out this issue as healthcare providers in our respective institution? When you look at the situation whereby to say to identify a patient in the ward, what does it require for you to identify a critical ill patient in the ward? There it's just a human resource, and maybe and things like blood pressure machine, a pulse oximeter. Is it what is missing in the ward? Is it what is not there? So when you identify such a gap, what is the next step to take? What is the action plan that you take for you to resolve the gap that you've identified? Is it to involve the direct supervisor and let them be aware that the machine have stopped working, that the thermometer broke down when you were doing your vital sign taking, when you were examining the patient, that the pulse oximeter has no batteries. So all are the small things that sometimes we miss, and then when we don't take good care of this and leading to failure of identification of patients. Okay. And now when it comes to like administration of the actual act of giving care to the patient, in there, what do we need when it comes to take care of the patient? Is it things like there's no space where to give the patient care from, lack of resuscitation room, lack of emergency drugs, or lack of essential drugs like oxygen, or untrained staff? What is it that we've identified as gap? And after identification of this, what have we done to improve the actual situation on the ground? So we have responsibilities as primary healthcare who are in direct touches with patients, who are first exposed to see these patients and identify them, and finding a gap that is in front of us. What solution do we take? Most of the time, we end up by not taking an action plan, not going further in our decision making. We identify the gap, but we leave it there, not bring it to the attention of people who are responsible for them to take care of the actual decision and sort out the little problem so that care of patient continues and it's given in good manners. That could be the summary that we would like to discuss in our breakout session, but unfortunately we couldn't because of some technical challenges. Dr. Opp, back to you.
Okay, thank you, Dr. Papytcho. I think that sounded like quite, it would have been a very nice breakout session because we all have these challenges in our institutions. For our breakout session, I'll ask Chawo. She says she was a bad secretary, but I think she got 1 or 2 points. Chawo, please come and tell the main group what we discussed from our end. Chawo, are you still here? Chawo, are you here? Okay, if Chawo is not with us, Richard, are you here? Okay, Sarah, please try to unmute Chawo. I think she was unmuted. She was muted.
Yes. She should be able to unmute herself now.
Chawo, the floor is yours.
Good afternoon, Dr. Hope and everyone. Yes, Dr. Hope, sorry, I said I'm going, right now I'm a bad secretary, but you said I should talk about what we discussed?
Yeah.
Okay, I think you talked about the signs that will make us, sorry. Dr. Hope, sorry for disappointing you.
Okay, no problem.
Okay, I can take it up.
Richard, yeah, Richard, please take over.
Okay, so we were looking at the clinical resources that are needed in the caring of our critical EU patients. So we looked at the use of the news or the air warning scores. We also talked about the use of the AVPU, the AVAP in looking at the patient that might be unconscious. Okay. We also talked about identifying looking at the airway signs. Is our patient able to say a few words without getting tired? Because this will give us a sign that this patient is having difficulties with the airway. Okay, so we also discussed having triage systems in our hospitals. If we have a proper triage system in our hospitals, we'll be able to identify the deteriorating patient or patient that will need assistance early, and then we'll be able to attend to them in good time and prevent them from deteriorating. We talked about also get information, rechecking on the intervention that we have taken. So if, let's take for instance, the patient was deteriorating with the SpO2, when we escalate on oxygen, we need to go back and check if the oxygen saturations have improved or not. If they have not, then we need to escalate and do something else which will help the patient improve. We also looked at the things that might cause a patient to deteriorate, one of which was doing transfers. When we're transferring patients such as COVID patients, we need to frequently monitor the patients so that we don't lose them on the way. We continue checking frequently, as opposed to the way we check traditional way. We want to check every hour or 2 hours like that, but we check often so that we don't lose the patient. We also looked at the ABCD approach. During the ABCD approach, we said that we need to attend to the airway. We ensure that the airway is patent. If there's anything that is obstructing the airway, we try to maximize by using some airway maneuvers so that we ensure that the airway is open. We can use oropharyngeal airways or padded spatulas or syringes so that we open the airway. And then we look at the breathing pattern. How is the patient breathing? If the patient is not breathing too well, what's causing the patient not to breathe too well? We attend to that. That's when we can move to circulation, then also look at disability. I think those are some of the things I got from our breakout session.
Okay, Richard, thank you. I think that was about it. Well put. Sarah, I think that's what our room has to report. So going back to today, I think the key practice change objectives for today were to define what acute care is and where can it be given, what critical care is and where critical care can be given, what is the difference between time critical care and intensive care, and we're told that the time pressure element is what makes the difference. We looked at what EECC is, the essential emergency and critical care services, and the need to expand this in universal health coverage. The key domains, which are identification and the actual care. We also looked at how care can be improved. The care that we provide as physicians or as clinicians can be improved for critically ill patients through education, training, the use of guidelines and protocols, and also using cognitive aids. This can be in the form of apps on our phones or booklets. We also looked at hospital preparedness, which Dr. Papytcho has told us about, identifying gaps and improving on this. I think lastly, in this COVID era, we need to advocate for oxygen supply. We need to make sure that oxygen as an essential medicine is available in our acute care setups, in addition to other EECC resources which are needed to provide care to critically ill patients. I think in closing, I'll end with what Teddy Roosevelt said: do what you can, where you are, with what you have. So in our variable resource setups, what we should emphasize on is making the most of our patient experience or improving the outcomes of our patients by making the most with what we have. So thank you. I'll ask Sarah to give us the closing remarks for today. Sarah?
Yes, thank you, Dr. Hope, for that excellent presentation. Thank you, Dr. Papytcho and Dr. Sipuka, for this wonderful information. It's very helpful. I know I speak for all of our participants when I say this is excellent information. So just a couple of reminders before we close out for the day. Everything that you saw on today's session, all of the resources, the PowerPoint slides, the extracurricular things can all be accessed for free on the Learning Resource Center when you make a free account. So go to this link and you will be able to access everything. We encourage you, please go back and re-listen to it, rewatch, read through the materials, very beneficial. And the recording of the session will also be available after this session. It'll be put on our website. If you would like to join our WhatsApp group, you can scan the QR code here and send us a message if you have any questions, and we would love to be in contact with you. Please join us next month on December 16th for the last session of this course. Our final session will be on final frequently asked questions and resources for oxygen and critical care. So please email echo@assistinternational.org for any questions, and we'd be happy to assist you. With that, thank you again to all of our partners, to Project ECHO and Assist International and Stanford for making this program possible. And thank you to our panelists for conducting our session today. Thank you all very much. We'll see you next month.
Bye-bye.
Thank you, bye. Yeah.
Alvin, can we close?
Yes, yes. Thank you.